This is a discussion of the algorithm in Chapter 224 on the management of preterm infants with posthemorrhagic hydrocephalus. This algorithm reflects typical management practices in the USA for a clinical pathway and should not be misconstrued as a statement of standard of care guidelines. Consideration must be given to the local resources, clinical practices, and population characteristics. This algorithm is a suggested starting point as a clinical pathway based on current research. Practice patterns will be refined as new data emerges. Here we'll be discussing this algorithm, which is an example of clinical management strategies for preterm infants with severe IVH. To begin, on head ultrasound, severe IVH is defined as grade 3 or periventricular hemorrhagic infarction, PVHI, formerly known as grade 4. Term infants have a different etiology. Most NICUs have an established timeline for serial head ultrasounds in very preterm infants less than 32 gestational weeks. Neurosurgery consultation after severe IVH varies amongst centers. Typically, neurosurgery consultation is obtained if any of the following exists: enlarged ventricles on serial head ultrasounds, full fontanelle and splayed cranial sutures, head circumference that crosses percentiles and exceeds the 97th percentile on a corrected growth chart. Note that very preterm infants typically have a rapid rise in head circumference. So to begin, preterm infants less than 37 weeks with severe IVH on head ultrasound. You consider neurosurgical consultation. Following yes, enlarged ventricles, splayed sutures, full fontanelle. If no, reassess with serial head ultrasound. For infants with enlarging ventricles, rising head circumference, and splayed sutures, neurosurgery typically assesses these patients. Serial head ultrasounds are performed to follow ventriculomegaly, and an MRI is informative but can be challenging in medically fragile neonates. CT scan should not be used due to radiation exposure. The diagnosis of symptomatic ventriculomegaly is a combination of imaging and clinical findings. Per HCRN criteria, FOHR greater than 0.55 plus any two of the following three. Number 1, FOHR greater than 0.55 is frontal occipital horn ratio. This does not cover every scenario. For example, porencephalic cyst from periventricular hemorrhagic infarction can impact ventricular dimensions. Number 2, episodes of apnea and bradycardia are common in very preterm infants and not always indicative of elevated intracranial pressure. Number 3, splayed sutures are a reliable clinical sign across examiners. 4, bulging fontanelle often occurs in the setting of splayed sutures. And number 5, please note that resistive index is not one of the criteria. So drawing your attention to the top right-hand corner, if there are enlarging ventricles, splayed sutures, full fontanelles, and a head circumference across the 97th percentile and crossing percentile, then neurosurgery consultation with brain imaging, fronto-occipital horn ratio greater or equal to 0.55 plus any two of three bradycardia, splayed sutures, bulging fontanelle. If no, continue to monitor and reassess with serial and weekly head ultrasound examinations. With respect to temporary CSF diversion, ventricular access device, VAD, serial taps to stabilize head circumference. VSGS, CSF collects in the scalp. Multi-center trial in the US showed similar rates of efficacy and complications for a VAD and VSGS. Typically, we do not use external ventricular drains, fontanelle taps, or lumbar punctures. Depending on the population, only 10 to 20% of infants with temporary CSF diversion will reestablish their own CSF dynamics and avoid permanent CSF diversion. Some centers use endoscopic procedures as a type of temporary CSF diversion. A multi-center clinical trial found that ETV-CPC for preterm infants with severe IVH and less than 30 days old corrected was only effective in 22% of the cases. So drawing your attention to the top right-hand corner, frontal occipital horn ratio greater or equal to 0.55 plus any two of the three of bradycardia, splayed sutures, bulging fontanelles. If yes, continue to temporizing CSF diversion procedure and potentially persistent need for CSF diversion. If no, continue to monitor and reassess with serial exams and weekly head ultrasound. With respect to permanent CSF diversion, temporary CSF diversion is longer use of temporary diversion reduces the need for revisions later in life. Ideally, reach 3 months uncorrected prior to permanent CSF diversion and can replace VAD or VSGS to extend interval of temporary diversion. Ideally, avoid permanent shunt insertion in the setting of infection. Perform MRSA decolonization if needed. Use of ETV CPC prior to 6 months corrected is not recommended due to high failure rate. So again, the top right-hand corner, persistent need for CSF diversion, if yes, age greater than 3 months uncorrected and absence of infection, then continue to permanent CSF diversion. If no, stabilize with temporizing CSF diversion procedures. And again, in the absence of these criteria, reassess with serial exam and brain imaging. So as a review, we provide an example of a clinical management strategy for preterm infants with IVH. Beginning in preterm infants less than 37 weeks with severe IVH on head ultrasound. Consider neurosurgery consultation. Once achieving neurosurgery consultation, look at FOHR greater than or equal to 0.55 plus any two of the three symptoms of bradycardia, splayed sutures, bulging fontanelle. If yes, continue on to a temporizing CSF diversion procedure, after which need for persistent CSF diversion will be determined. If yes, persistent need for CSF diversion ideally is done in the context of age greater than 3 months uncorrected in the absence of infection. Thank you.